Welcome to another episode of Dr. Doctor, the award-winning radio show and podcast featuring your physician hosts, Dr. Tom McGovern
and Dr. Chris Stroud. And this is the show where we and our guests will discuss relevant health-related topics and always from an authentically Catholic perspective. Now, Dr. Doctor is brought to you in part by the generous underwriting of our friends at CMF Curo. You can learn more at mycatholichealthcare.org. Live your Catholic faith in your healthcare with CMF Curo.
Today's show will air across the EWTN Global Catholic Radio Network. Rejoining us on the show will be pediatrician Gwyneth Spaeder. Gwyneth has a great interest in viral infections, and she's going to talk about this crazy triple-demic thing that's going on, the increase in RSV in kids, influenza in kids, as well as maybe even COVID-19 if it's really happening in kids. We're going to find out more from her because hospitals are filling up. I mean, aren't they, Chris? You just had an extreme experience recently.
Yeah, I mean, you might say, how is this relevant? It's relevant. The combination of influenza and the RSV, or the respiratory syncytial virus, has hospitals just packed, and especially the emergency rooms. And you and I were talking before we started this episode. Just a few days ago here in our community, I couldn't get a patient out of the emergency room and into a hospital bed because all the beds were full. And so it really is a tough combination. And it could just be me. Maybe I'm not paying attention, but I don't feel like we're hearing nearly as much in social media and in the news about all that's going on now with RSV and regular flu, because it really is taking a serious toll, if nothing else, on healthcare resources.
Yeah, I was recently on the CDC website where they keep pretty good track of the flu cases, and compared to the last few years, it is incredible, the steep rise of the curve. And in fact, 1 out of every 4 people tested who think they might have the flu have the flu. That's just an incredibly crazy high number that many people have influenza. In fact, the stats so far, and we're only, a month or two into the flu season, so far in the United States, as of last weekend, 8.7 million flu illnesses, 78,000 hospitalizations, 4,500 deaths. That's just nuts. Now, this is all comers. Tonight's episode's mainly going to focus on kids, but we've got something insane going on with respiratory syncytial virus, or RSV, which is typically a disease of babies.
Right, of newborns and neonates. We'll be sure to put that CDC website that you referenced in the program notes that go with this episode. We would tell you, but it's sort of a long, drawn-out HTML, but we'll get you that link. So if you want to follow that and get up-to-date numbers, you certainly can. But it really is it's sort of an understated, I'm almost afraid to use the word pandemic. You said tridemic, I think you said at the beginning.
Triple-demic, yep.
But it really is remarkable, and much more so, I believe, than we've seen in years past. And I have to wonder, I can't wait to ask our guests, if any of this has to do with a post-COVID effect. And by that I mean, are we more or less likely to have gotten our flu shot because of all of the hoopla that came about the COVID vaccine? I wonder if in people's minds maybe those are getting commingled, or is there something unusual going on like that that's making flu seem to be a lot worse this year?
Well, there's also something they're calling the immunity gap that we have lost because of the lack of protection, or the lack of contact with those viruses that we normally would have had the last 2 to 3 years. As I've heard it said, masks were somewhat effective at helping reduce COVID transmission, but extremely effective against influenza. I mean, the numbers the last 2 years were minuscule compared to normal. But I don't think our society wants to go back to wearing masks to reduce influenza. Do you, Chris?
No, I'm going to go with a universal no on that one. Or at least that's my vote. Now, this is tricky. Don't shoot the messenger. But while there's plenty of room to debate the pros and the cons and the ups and downs of the COVID vaccine, I just don't think that's true with the flu shot. It actually can help you not get the flu. But of course, people still get the flu after they've had their flu shot.
Right.
But the severity of that infection is dramatically reduced. And I really, honestly, listeners, I don't think that's debatable. If I'm wrong, please Please tell me, as I know you will. Uh, but but I don't think that's wrong. And so I would get a flu shot. Tom, what do you think?
I got mine again, and I get one every year. Now, admittedly, the results are that it's less effective than the COVID vaccines available in the U.S., but it still can help reduce the severity of disease, which is a good thing. And unlike COVID, which was mostly fatal the older you got or the more comorbidities you had, influenza is kind of bimodal. It affects young kids and the elderly. So it's not just at the old end of the age spectrum, it's also at the young end where it can be bad.
Well said. And that was hypothesized some with COVID, but we're not new to influenza and RSV, as our guest will help us understand. This is nothing novel. We've been dealing with these viruses for a very long time, which means we've got a tremendous amount of public health experience through the decades as to how these viruses behave and how the population of people behave when they're affected or infected with these viruses.
Yeah, I don't know about you, but I've had more patients cancel their surgery in the last several weeks than I've had, since the beginning of the COVID pandemic.
Yes.
It's just, have you too?
Yeah, exactly. I just had that this week, and the nurse told me your next case is canceled. They tested positive, and I thought, oh, COVID. She said, no, 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 I didn't mean COVID. I meant influenza. But exactly. I mean, people are sick, and they have to cancel work and miss school, and it's a real pain to have influenza.
Yeah, I had a staff member couldn't come in because their child's school closed because they had 23% of kids sick. Somebody else didn't have school because too many of the teachers were sick. And this, looking at the flu intensity across the country, I mean, states almost, I'd say 80% of the states are in a severe range for flu. It's just nuts. So we'll get some perspective from Gwyneth Spaeder. But before that, you must endure another medical trivia question. And the category, the lungs, since we're talking about respiratory infections. So lower respiratory infections include all infections below the level of the larynx or the voice box, which starts at the top of the trachea or the windpipe. So these infections include the lungs. So here's some basic questions about the lungs. 4 questions, but they're easy. Well, they're easy, quick answers. How many lobes does each side of the lung possess? How many on the left? How many on the right? 2, is the right lung or the left lung taller from highest to lowest part? 3, is the right lung or left lung wider? One of them is. And 4, which lung can hold more air, the left or the right? So we'll be back with these lung-related questions after our interview with Gwyneth Spaeder, which is coming up next after the break here on Dr. Doctor. Welcome back to Dr. Doctor. We have with us now Dr. Gwyneth Spaeder, a pediatrician from North Carolina, who attended the University of Dallas in Texas, where she graduated with a degree in, what else? Political philosophy. Helps to become a good pediatrician. She then attended the Johns Hopkins School of Medicine, a little school, I think, somewhere near Baltimore, graduating in 2005. She's board-certified pediatrician. She's practiced in both community emergency rooms and private practice settings. She also completed a certificate in healthcare ethics at the National Catholic Bioethics Center, and she's published several articles pertaining to vaccine ethics. She's also served as guest editor of the National Catholic Bioethics Center Quarterly, focused on pediatric issues. She's a recurrent presenter at Theology of the Body workshops for teens and for natural family planning and marriage prep in the Diocese of Raleigh, North Carolina. She's a member of the Catholic Medical Association Triangle Guild. She lives in Wake Forest, North Carolina with her husband and 3 children. Welcome back to Dr. Doctor, Gwyneth.
Thank you so much. I'm happy to be here.
Hey, so what is the big deal in pediatric hospitals across the country? Why are some nurses complaining about the state of these units? And why the heck are some of them even asking the president to declare a national state of emergency?
I think there is a crisis of sorts in pediatric hospitals right now. And the crisis comes from what I would call a mismatch between the number of pediatric patients requiring hospital level care and the number of beds available to provide that care. And I think it's important to understand when people in the medical world speak of beds, we're not just speaking of a piece of furniture. We're actually speaking of the combination of a piece of furniture in a hospital with staff available to take care of the person in that bed. So my understanding is that this is less a problem of physical space and more a problem of staffing. Both nurses and doctors have left the medical field in large numbers over the past few years, and those people have not necessarily been replaced yet. So we have kids pouring into the ERs, they need to be admitted, and there's just not available beds to put them there. So they end up camping out in the ER for hours, if not days, and it leads to an incredible backlog.
Well, Gwyneth, I mean, if we could just imagine that there was life before the pandemic, if we think back to 2017, 2018, and those happy years, we had RSV then, we had influenza then, and we've had each of those for a quite long time. But is there something different about today with these two viruses versus back in the pre-pandemic years?
I think it's a great question. I think it is not necessarily that we know that there's something different this year about the RSV strain or the influenza strain, but this combination of resources and a cohort of pediatric patients who were so isolated over the past couple of years due to masking and social distancing that they were not exposed to these illnesses. And they're all being exposed at once. So instead of 1 year's worth of young infants, we're talking about 2 or 3 years worth of young infants that are seeing these illnesses for the first time.
So have we proven that masking and distancing is effective for reducing influenza and RSV?
I would say we have proven that without a doubt. I mean, I think that there's all sorts of interesting debates still to be had about the role of masking in various situations. But it's actually fascinating to me when I was preparing for this and I was on the CDC website to look at the influenza curves. If you can pull up, by year, the rates of influenza. And it literally, there is no curve in the 2020, 2021 graph.
Nothing.
It's a blank graph. And the RSV curve didn't completely disappear like that, but it did go down substantially. And I think the only possible explanation is this combination of masking and social distancing.
So we know that it works for those, not that we are doing those same things because we value other things more than that right now. So we're back to where we are now. So is it like 2 or 3 years worth of kids now that would have been spread out are now getting something all at once?
Yeah, I mean, I think that's probably the most the simplest way to look at it and the most logical explanation for this. And then you combine that with probably less resources. And also, frankly, parents who are not used to seeing sick children. I think that there's an entire cohort of parents who, if they did not have kids before COVID, have never watched their children their young children be sick. And I think all of us as parents can remember back to how terrifying it is the first time your baby is sick. And all of those people are rushing to seek medical attention at once. Yeah.
Now, what is this phrase immunity gap? This idea that kids are reduced contact with other kids, and as a result, they've not been exposed to stuff that they're usually exposed to. Is there something there to that?
I think there is something there to that. I hear it referred to in a variety of ways. The phrase I do not like is weakened immunity. I don't think we have any evidence that there's anything wrong with these kids' immune system. Right. It's simply that they just have not had the training camps that used to be the normal experience of your first few years of life, especially if you were in daycare or preschool or Mother's Day Out programs or what have you. Those literally did not exist. So you can now have a 2 or 3-year-old who is entering the Petri dish for the first time. And instead of having 3 years of slow exposure is getting hit with everything all at once. So I think there's probably going to be some very interesting studies to be done about immune development in children over time. It's going to take a while for us to sort all of this out. I don't know what the long-term immune development for a kid who, say, was born a couple years before the pandemic, got the first 2 years of normal exposure, then everything came to a grinding halt, and then jumped right back into kindergarten. Like, does that make that immune system somehow different than someone who went through kind of more typically as we all did? I don't know. Time will tell.
Wow.
So
let's focus on RSV
Yes.
a little bit, because it sounds like that's kind of the big story, at least from the kids' perspective.
Yeah.
Walk us through that. What exactly is RSV?
So RSV is the shorthand term for respiratory syncytial virus. It's actually an incredibly common virus. It's been well known and described since the 1950s. I did not know this. I learned this while getting ready for this show. It was initially called the chimpanzee coryza virus. After it was it was initially discovered in a chimpanzee animal research lab, where there was an outbreak, and it was only after some studies were done that they realized that the virus had actually originated from the human handlers of these animals, not the chimpanzees. So it was renamed, but it's a very common virus. It starts out as an upper respiratory infection with your typical sore throat, runny nose, fever, possibly headache. And then for most, it will kind of descend to a very mild lower respiratory infection with some coughing. But there are those for whom the lower respiratory system involvement becomes much more severe, and you have significant coughing, wheezing, difficulty with oxygenation. And that's what gets particularly young babies into trouble.
So you sort of spoke to it, but young children get it. But in general, who gets RSV?
Yeah, so I heard two questions there, so I'll try and tackle them. You can definitely get it more than once, unfortunately. I don't think there's any limit to the number of times you can get it. The strains do change over time. I think, each subsequent exposure is likely to be a little bit less severe, but it's certainly not a once and done illness. Prior to COVID, almost universally, everyone had their first RSV infection before the age of 2. And that's independent of whether you were in daycare or at home. It was so prevalent that everybody got it. So it primarily affects the very young, and then also, of course, the very old, those with chronic lung diseases, those with significant cardiac diseases, and anyone who's immunocompromised.
So how has this year's RSV curve differed from other years pre-pandemic?
Yep.
Yeah, it's mostly the timing that's been so strange. I mean, when I was in training, and then even, the first 10 or 12 years that I was in practice, RSV existed between October and March, and that was it. I mean, it was written in stone. It would never have even occurred to me to test or think about RSV outside of those months. And then something very strange happens during the pandemic, and RSV kind of went away for that first winter. So, fall of 2020, winter of 2021, and then had a strange resurgence in the spring of 2021 and the summer of 2021, 2 little blips, which I think caught everybody off guard once they realized what was happening, because none of us had ever seen it at these times of years. And this was particularly problematic for the most vulnerable patients, our premature infants, who are typically receive a prophylactic monoclonal antibody during the typical RSV month, so from October to March, and no one was prepared or even thought to have it ready in April or June of 2021.
So I didn't realize that preemies get it. So how early do they have to be born? When are they given it? How are they given it?
Yeah, so the most recent guidelines limit it to, there's incredibly specific guidelines, but in general, you need to be born before 29 weeks gestation and or have significant chronic lung disease or congenital cardiac disease to be eligible during your first RSV season that you are kind of out in the world. And it's a once a month injection that's given in your pediatrician's office, typically given from October to March. But by the summer of 2021, people were starting to think about, oh, well, maybe we have to rethink how we dose this. It's a very expensive medicine, so that's why it's given to only the most high-risk infants and only when it's approved to be given. But there was approval given this past summer for infants to start getting it. And the American Academy of Pediatrics actually just put out a press release 2 or 3 weeks ago suggesting that we just continue giving it. If there were babies who started it this summer, even when they reach their typical 5-month allotment, they continue to get it if there's continued high rates of RSV in their community.
Well, now you've mentioned a couple of times season, but this one isn't following the rules. So how long do you think this season, so to speak, is going to last, or can you say?
I don't know that there's any way to say. If I was being really optimistic, nationally speaking, and here in North Carolina, the numbers are falling. They've been falling for about a month now. So I'm hopeful that we're over the worst of this surge, but I don't have any way to know if we're going to have another spring blip like we've had the last 2 years, or if this will be it until next fall and it will kind of settle back down into a fall winter virus again.
How are the ages of those affected now different than the ages of the kids who got it, say, 5 years ago?
The littlest babies are still the largest cohort that are requiring either ER help or hospital admission. But I'm hearing from my pediatric colleagues around the country that they, particularly those friends and colleagues who work in hospital systems, that they are admitting more preschool and older toddler age children than they ever remember having done before, and that they're seeing a lot more secondary bacterial pneumonias than they remember seeing in these age groups before. And again, is that this difference in immune exposure over the past 2 years? Is there something different about this year's RSV strain? I just don't think we know yet.
Yeah. So Gwyneth, if you're looking at a child in the emergency room that has RSV, what's going through your mind as the pediatrician in terms of trying to decide, do we have to find a bed in the hospital for this child, or are they going to be okay to go home?
Yeah, it's a great question. And I did this actually for a couple of years right out of residency. I worked in a community ER in Baltimore, and I can't tell you how many hundreds, if not thousands, of RSV babies I've had that thought process for. So, first and foremost, I look at their breathing. Are they maintaining oxygen levels on their own, or adequate oxygen levels on their own? And then, presuming they are doing that, can they coordinate eating and breathing at the same time? So for the most part, these are infants who are eating either by nursing or taking a bottle. And it actually requires a fair amount of coordination to be able to suck and swallow and breathe all, and not choke all at the same time. So often what will actually get these babies admitted to the hospital is not necessarily their oxygen levels, but their inability to stay hydrated. So it's one of those two things that will push you towards admission.
So I understand that some of these kiddos have a lot of wheezing, like asthma patients.
Yes, they do wheeze. It's a different kind of wheezing than asthma. And pediatricians who have been doing this long enough will, not 100%, but with some certainty, be able to put a stethoscope on the back of a baby or toddler and say, oh, yes, that sounds like RSV. So it's definitely wheezing as we would define wheezing, in that there's constriction of the airways that's making a noise when air passes through it. But there seems to be a different underlying pathophysiology, because these kids do not respond to albuterol the way a typical asthmatic would. So when I was initially training, and I'm not that old, we gave all of these kids albuterol, because kids who wheezed got albuterol. That's what you did. It was supposed to relax the airways and and make it easier for them to breathe. And a lot of them also got steroids because that's what we did for our asthmatics, and it seemed to help. But there were new guidelines released, I think it was 2014, 2015, looking at several meta-analyses and some good studies that really showed that neither albuterol or steroid use decreased rate of initial hospitalization or length of hospital stay. So it is now no longer recommended in the treatment of these RSV patients. Although I will say, particularly this year where we have this cohort of older children being affected by RSV, if they have a strong history of wheezing independent of RSV, I will still try albuterol in my office because those kids we know have reactive airways. And whatever the trigger is, the hope is that we can calm their reactive airways with the albuterol.
Yeah. Gwyneth, I mean, RSV to me sounds like a viral infection just begging for a vaccine. What's the story with RSV and vaccination?
Yeah, it would be fantastic, right? It would maybe put me out of a job in the winter months, but it may be coming. I think there's a couple reasons. I actually found the reading on this very interesting. There's a couple reasons why we don't have one yet. There's both a historical and a scientific reason. So the scientific reason is that apparently the target antigen, similar to the spike protein that we all got used to hearing about with the COVID vaccine, that the target antigen in RSV is something called the F protein. And it is what is known in the immunological world as a shapeshifter, so that it changes form as it attaches to the target cell and integrates itself into the host. And that makes it harder to design a vaccine, an effective vaccine against. So there's that issue. There's the issue that, as we talked about earlier, you can get RSV more than once. So you can't just design a vaccine that's going to mimic the natural immunological response of people who have had it, because it won't last. So you have to come up with something more than what the humans do on their own, the human immune system does on its own. And then there's a historic reason. So in the 1960s, there was an attempt made to create an RSV vaccine, and it was given to a cohort of young children, and they tolerated the initial vaccine very well. But then when they were subsequently exposed to RSV, several of them had exaggerated immune responses, ended up hospitalized, and 2 of them actually died. And it was a horrible moment in vaccine history, and I think it scared a lot of people off for years, if not decades. In my reading, it seems that vaccine, they were trying to target the post-fusion F shape, whereas the more modern vaccines are going after the pre-fusion F shape. But that's about the level of my immunology understanding. So, but the good news is there is an RSV vaccine. Both Pfizer and GSK have ones in phase 3 trials in older adults. So Pfizer has released fairly promising looking data from a randomized control trial in adults older than 60 that showed up to an 85% decrease in severe disease. And so the hope is that, like the COVID vaccines, if it works well for the adults, we'll be able to start trials in children shortly.
Well, if we move from RSV a little to what you might call regular flu or influenza.
And that would be great right after this break that we have scheduled right now on Dr. Doctor. We'll be back more because Chris is chomping at the bit to ask a great question to our guest, Gwyneth Spaeder.
Well, welcome back to Dr. Doctor, and welcome to more discussions on fascinating things viral. Just before we took a break, we were about to start talking about influenza. So moving from RSV to what you might call regular old flu for short, or influenza. So where are we with kids and influenza, and is there something special going on this year with that problem as well?
Yeah, I think similar to RSV, although it's clearly a different illness, there appears to be kind of a huge surge in pediatric flu cases, and those flu cases requiring hospital attention. than we've seen easily since the 2019 season. And if the numbers continue as they're projected to continue, because we're very early in the flu season, it's being suggested that this will be the worst flu season since 2009, which was the swine flu pandemic that I cut my teeth on as a brand new pediatric ER attending. So it looks to be what we in medicine call a quote unquote bad flu season, meaning more individuals will get sick. Those that get sick will get sicker than usual. More people will require ER or hospital attention to get over it.
Now, again, you mentioned earlier when you're looking at a child trying to decide if they come into the hospital, is that the same issue with influenza? Is a child more or less likely to need hospitalization with influenza?
Yeah, I think it depends a bit upon the age of the patient.
Sure.
So the very young babies, the 6 months and under, I typically see do better with influenza, generally speaking, than they do with RSV. Whereas the older kids, particularly those with underlying health conditions like bad asthma, are likely to do worse with the flu than they are with RSV. So there's a bit of an age split there.
How do the influenza symptoms differ from the RSV symptoms, say, in kids before school age?
I mean, there's a lot of overlap. And so I don't know that it's necessarily possible for a parent or even a pediatrician to look at a child and say, oh, this is flu, or, oh, this is RSV. As I think I said earlier, there's a sound to the lung exam for RSV that's slightly different than that for influenza. But, both are going to start with fever and headache and sore throat and runny nose and cough. I tend to see higher fevers and more persistent fevers with influenza. And in the older kids, more complaints of kind of body aches and just feeling bad. Whereas RSV, in kids who are old enough to express anything about it, is really more a bad head cold. It's more just the amount of congestion up in the head. But yeah, there's a lot of overlap between the two.
So, we all probably, Tom and I especially, have a little PTSD from talking about vaccines in the last 2 years. But I mentioned earlier, the flu shot for children. I think it's not controversial. Now, I'll probably get hate mail for that. But maybe you could speak a little bit to the flu shot for children and how you counsel parents to find their way sort of through that topic.
Sure. Yeah, I would agree with you. I don't think it's controversial in the way that the COVID vaccine was or is still considered by some to be controversial. With that vaccine, I think parents that I spoke to were concerned about how new it was and was it safe.
Yeah.
And with flu, I do find that a lot of parents decline it, but it's more so because they just don't think it's necessary. And, they don't like giving their kid a shot, or the kid doesn't want a shot. I have a lot of parents who will turn to their child and say, do you want it? Which I think is a crazy thing.
Really?
To ask. Sure, Mom, I would like an extra needle. But yeah, I can't tell you how many times I've seen that. So what I try and tell parents is that it is true. The vast majority of healthy children who get the flu will be, uncomfortable for a few days, and then they will be just fine. But I encourage the flu vaccine for everyone, and I give it to my entire family, including my children, every year for two reasons. One, to try and decrease community spread as much as possible for the more vulnerable in our population. But two, because every year there are, 100 or so previously healthy children who die from the flu. And almost universally, those children are unvaccinated. So what I tell parents is that I can't guarantee that getting the flu vaccine will mean that your child will not get the flu, but I do it so that they stay out of the hospital and they don't die.
What do we know about the strains of this year's flu? Are they bad ones, good ones, in between?
So the prominent strain seems to be this H3N2. I think I have those letters and numbers
That's
correct.
right.
And
You
that was
do.
what was seen almost exclusively in the Southern Hemisphere, which is always our sneak peek for the flu season. That when I looked at the most recent numbers here in the United States, it was 75 to 80% H3N2, and then the other 20 to 25% was H1N1. The H3N2 seems to be a slightly more aggressive strain than H1N1, so it would be nice if that 25% could spread a little bit more rapidly, but we'll have to see. The good news is that both of those strains are included in this year's flu vaccine, which should give us some benefit. And in the Southern Hemisphere, it was described as moderately effective. Each year they quote between 40 to 60% efficacy
Right.
for the flu vaccine. And, the numbers out of the Southern Hemisphere look to be about 50%, so right smack in the middle. So I would say moderate is an accurate description. But again,
So
I
how do you
would say with that 50%, people would say, oh, I might as well flip a coin. It's not quite that simple. That's 50% to not get the flu, but that doesn't take into effect or take into account how sick you get with the flu, whether you need to go to the hospital for the flu. So even when you catch it, it will give your immune system a head start to fighting it off.
So Gwyneth, compared to pre-COVID, how are vaccine rates among patients, pediatric patients, for flu and for other vaccines? Has there been a shift?
Yeah, they're down. Vaccine hesitancy is something any pediatrician has dealt with their entire career. It certainly existed long before COVID, but there's more in my practice, more parents concerned, more parents questioning. There's been a lot of bad information spread about over the last 2 or 3 years, and it's understandably confusing and upsetting parents who are trying to make the best decision for their children. In general, I find I can talk parents through it if they're willing to come in and talk about it. So that's been my personal experience. Nationally, we are definitely down a percentage point or two in vaccine rates, which doesn't sound like a lot, but when you talk about the pediatric population of the entire United States, is an awful lot of children running around behind on their vaccines. That's a combination of vaccine hesitancy, but also just, pediatric offices were closed for a long time. And even when they opened, parents were hesitant to bring their kids in unless they really felt they needed to be seen. And so we just have a lot of catch up to do. And I think we will get those kids caught up, but it's going to take some time.
So what do you think the rest of this season looks like? I should say right now, how many kids are in the hospital compared to a normal flu season?
So I'm not sure if I have the exact numbers for flu, but I did look at it no, I'm sorry. I was going to say, I don't have the numbers for RSV. I do have the numbers for flu. So in my county alone, Wake County, North Carolina, we are admitting about 80 pediatric patients a week for complications of the flu. The national statistics, I think it was about 30 kids under the age of 4 per 100,000, and 17 to 18 kids between 4 and 18 per 100,000 across the country. And those numbers are higher than anything we've seen in the past 3 or 4 years, but it's still so early in the season. I don't know how it'll compare to numbers for years prior to that.
So is it a higher percentage of kids with the flu now are sick enough to be hospitalized compared to other years?
I think it's both a higher percentage are sicker and there is more flu. So it's spreading faster in school systems and daycares and preschools and church communities.
So a local school here, they closed because they had 23% of their kids out to do some deep cleaning in the school. Does that deep cleaning have any effect on spreading the flu that you know of?
I don't know that the deep cleaning does. Separating the kids for a period of time, I think probably is effective, but it's not a long-term solution unless we want to go back to, the early COVID pandemic days and just shut everything down, which I don't think anybody is suggesting at this point.
So what symptoms should worry a parent that they should bring in a kid with a respiratory infection this season?
Yeah, that's a great question. So I always tell my parents, first and foremost, how is the kid breathing? Is it different than how they're normally breathing? If they have a high fever, they're going to be breathing fast. So
define high fever. Is it 100?
High fever? Yeah, so I guess that's a fair question. So I define a fever as anything over 100.4. You will see a
high fever. What's a high fever?
Yeah, high fever. I've sat at home with one of my own kids at 105.5, and I was starting to think, that's getting up there, but we stayed at home. So, it's not the number, it's what the number is doing to the child. So you'll start to see increases in how fast the kid is breathing, probably around 102, 103. But if your child is 103 and is willing to cuddle up with you on the couch and is coughing and doesn't have much of an appetite, but is happy with their popsicle and wants to watch cartoons, you do not need to come in. If your child is 101, but won't even lick a popsicle and kind of just moans and won't interact with you, that child needs to be seen. So I really try and encourage parents not to focus on the number, but how their child is looking and how hard they are working to breathe. Are they having to use extra muscles in their ribs or in their belly to move air in and out? And are they willing to have treats that you wouldn't otherwise give them? A child that turns away ice cream and popsicles probably needs to be seen by someone.
Well, I'll tell you, if my 14-year-old cuddles with me on the couch, I'm bringing him in because something's wrong.
Okay, fair enough. I'm mostly speaking about the little kids.
Oh, okay. All right. Well, I mean, along those lines, though, you deal with controversy every day. It's the nature of your practice. So we'll go on to something even more controversial, right?
Fantastic.
The use of antibiotics.
Oh, okay.
So,
all right.
I know you hear this all of the time that, my child needs antibiotics. Can't you just call them in something? They're coughing. They've got a fever of 100 and something.
Yeah.
Here's your chance to talk to parents as the expert. Make us understand, when does a child need antibiotics for a respiratory infection?
Yeah, that's a great question. So for me, that decision is always based both on the history of the illness and the physical exam of the child. So, almost all, I'm trying to think if there's any exceptions to this, almost all, upper respiratory and even early lower respiratory infections in the pediatric population start as viral illnesses. Antibiotics treat bacterial illnesses. So antibiotics are going to do nothing for the standard head cold. They will do nothing for RSV, and they won't help influenza. But the children that do need antibiotics are children who develop what we call secondary bacterial infections. So bacteria love mucus, and kids with head colds have a lot of mucus. So it gets stuck in their ears, it gets stuck in their nose, it gets stuck in their chest, and bacteria get in there and can cause trouble. And that's where antibiotics are indicated. So a kid who's on the first day or two with a fever and a runny nose and a cough is almost never going to benefit from antibiotics. A child who had those symptoms seemed to get better for a few days, and then all of a sudden the fever comes back and they're not sleeping well and they say their ear hurts or they're pulling on their ear. That child needs to be seen again for a possible ear infection that would require antibiotics. And in an older child, like your 14-year-old, a kid who had a fever and a cough and a runny nose and felt like crud Monday and Tuesday, and then by Friday was feeling a lot better. Saturday, we thought we were in the clear. And then Sunday, again, febrile, chest hurts, coughing, no appetite. I want to listen to that child's lungs to make sure he doesn't have a pneumonia.
That's pretty interesting because, the answer is that proverbial it depends, isn't it?
Yeah.
But I mean, it sounds to me like a message to parents is just because your child doesn't need antibiotics today doesn't mean that they will not need antibiotics 5 to 7 days from now.
Yes, and
So
that's
you got to keep thinking.
Yeah, thank you for that, because I think it's understandably frustrating to parents when they're seen initially, they're told, oh, this is just a virus, and then they come back 5 days later and they're given antibiotics, And it's on us as the pediatricians to make sure we're explaining, no, it's not that something was missed at your initial visit. It's that these illnesses and these diseases evolve over time. And so what we're treating now just wasn't present at the beginning. And particularly with the way people use urgent cares and minute clinics and all this kind of stuff today, there can be a lot of confusion if you're seeing multiple different providers within the course of one illness.
So maybe a word or two about why you're reluctant to not just prescribe antibiotics for everyone. You're not just being stingy, but maybe speak to that issue of sort of antibiotic stewardship.
Sure. So antibiotic stewardship is a term those of us in medicine spend a lot of time talking and thinking about. And it's basically the concept that antibiotics are wonderful drugs, right? I mean, they've saved countless lives and prolonged countless lives, but they are not risk-free. They do have side effects. In children, the most common side effects are upset stomach, rashes, sometimes true allergic reactions, all of which are unpleasant. But even perhaps more important than that is the idea that the bacteria that we are trying to treat are smart. And they are constantly trying to find ways around the antibiotics that we have to kill them. And the more that we give someone who doesn't need antibiotics a chance, the more we give that person antibiotics that aren't needed, the more the bacteria out in the world have a chance to kind of take a look at that antibiotic and figure out a way around it. And so they become less and less effective over time. And we get what are known as drug-resistant bacteria. And that becomes a huge problem, kind of on a social, national level.
Yeah, thank you. Well said.
So Gwyneth, to go back to differentiating bacterial from viral. So the color of mucus and the level of the fever do not differentiate between the two.
Correct.
Thank you. Because so many people think
100% correct. I don't care if the mucus is purple or, fuchsia or, certainly green, yellow, whatever. No, it really, it is one of the most common things I hear about, but now it's green, so they need antibiotics. No, it's not true. It's not true. It's just not true. Believe me, I have 3 kids of my own. If I could make these, runny noses and nighttime coughs and all of this go away with a dose of antibiotics, I would be doing it. But I don't give it to my own kids and I don't give it to my patients unless it's.
So what is the best treatment for somebody that has these symptoms and they have a viral infection?
Yeah, it's grandma's remedies. It's rest. It's staying hydrated with lots of fluids. It's time. If your child is miserable from their fever, by all means, give them Tylenol or acetaminophen or ibuprofen. But really, even in 2023, we have very limited means of treating these illnesses other than supportive care.
And when should they stay home from school and when should they go back?
Yeah, so this is interesting, right? This has changed a lot throughout the pandemic. So the classic rules and the ones that I've more or less shifted back to at this point are, 24 hours fever-free, which again, I define as a fever as being equal to or over 100.4 degrees Fahrenheit. So they should be fever-free without medicine for 24 hours. No vomiting or diarrhea for 24 hours. And their cough should be under control enough that they're not going to be disruptive to the class. I mean, unfortunately, some kids really do hack with these illnesses. And while they may not be terribly infectious, it's just going to be disruptive. And it's, the child is not going to learn well under those circumstances either. But I will say that I still have in my area many schools that are requiring negative viral testing to return to school. So I see a lot of kids who don't need to see a doctor, but are just coming in for their nose swab.
Wow.
Gwyneth, thank you so much. This has been incredibly practical for our patients and listeners. So God bless you. Hope to have you back.
Thank you so much. It's always a pleasure. I appreciate it.
Well, welcome back to Doctor and this fascinating discussion on all things respiratory. And that brings us to the answer to this episode's trivia question. We're just longing to understand the answer here, Tom.
Yes, we are. 4 parts about the lungs. Number 1, how many lobes does each side of the lung possess? 3 on the right, 2 on the left. All right. Now, and that's probably because the heart shifts a little to the left. Number 2 is the right lung.
We should probably point out you only have 2 lungs, but within each of those lungs, there's lobes, and they're different left to right.
That's right. And so is the right lung or the left lung taller from top to bottom? And actually, the left lung is taller because on the right side, the liver on the right pushes up the diaphragm to make that lung shorter. Number 3, which lung is wider? Well, it's actually the right lung because the heart smushes the left to the side. I think that was the word they used in the article. And finally, which lung can hold more air? Again, it's a heart-related question. Pressing on the left, the right lung can hold more air. So now you know 4 more things about the lungs you may not have known before. But now let's hear some things again that were highlights from Gwyneth. And Chris, your top 3 takeaways.
Well, it's no surprise that she's a terrific guest. She's an expert without sounding stodgy and academic. And so I think her parents, the parents of the children she cares for, are lucky to have her, most definitely. But I think one of the takeaways has to be that RSV is a big deal, right? I mean, it's serious. It's a very serious respiratory infection, especially for the premature babies and those that are ill, and even older children that have what we call comorbidities or other problems like congenital heart disease. So we need to pay attention to RSV, stay up with what's happening in your community, and if there's any question, talk to your peds provider about it. Secondly, I think a very practical tip that she said about fever. It's not the number, it's what the number is doing to the child.
Yes.
So as she pointed out, if your child has 103 fever, but they're snuggling with you, they're eating, they're acting pretty normal, that's not necessarily serious. They don't necessarily have to go in to be checked around a bunch of other sick kids.
Yes.
And then I think we would be remiss if we didn't mention this idea of antibiotic stewardship. So, kudos to all of our pediatric provider colleagues, like our co-host, Dr. Andrew Mullally, who are trying to do the right thing with antibiotics and at the same time trying not to alienate the parents of their patients. But I thought she did a great job of pointing out that just because they say your child doesn't need antibiotics today on Monday because it's a viral infection, it may be a bacterial infection by Friday that's been allowed to set up because of all the mucus that the viral infection caused. So don't be afraid to recall your peds provider, to go back and say, he or she got better, now they're sick again, because that second time, they really may need the antibiotics.
That was explained so well. Worth the price of the episode, which should be free for most of you who are listening to Dr. Doctor. And we thank you for doing that. You can find this and all of our old episodes on our website, drdoctor.org. Just click on episode archive at the top and you can search from over 300 episodes by topic or guest.
And now we offer a video version of this podcast. You can just click on the YouTube link near the top of the homepage at drdoctor.org and check out the video version if you like. If you have a question, if you have a comment about something wrong that maybe Dr. McGovern said, we'd like to hear about that. So click on Submit a Question. Give us ideas for episodes or any questions that you might have.
This is Dr. Tom McGovern.
And this is Dr. Chris Stroud. We're signing off until your next dose of Dr. Doctor.